welcome Tracy King today for our next talk, which is myeloma, an overview of the treatment and side effects. Tracy is a myeloma clinical nurse consultant at the Royal Prince Alfred Hospital, and she's also a clinical associate professor, a research fellow, and a lecturer at the Cancer Nursing Research Unit at Sydney University. Tracy has just over 30 years, although she doesn't look it, over 30 years experience within hematology, and we are very grateful that she has flown to us today from Australia to be with us here. So please do put your hands together to welcome Tracy.
Thank you so much, and thank you so much to the Leukemia and Blood Cancer Foundation for the invitation. I always enjoy coming to New Zealand on so many levels, and it's delightful to see us all meeting again, nearly all in person, although that virtual Zoom environment still does plague us when people are sick and can't participate in. But it is so much nicer to meet in person and be here with you. So I've been given the task of giving a bit of an overview of what is myeloma, how do we treat it, and what are some of the common side effects. And that's a topic that would have us here for at least a week, if not 2 or 3. And we've got about 40 minutes. So the nature of the presentation, it is being recorded, so you can watch it again at your leisure and look at some of the content and do that in a slower way. I am going to whiz through things quite high level, and we'll have some time at the end to take some questions. So do think as things come up, if I whiz past something you're very interested in, then keep it for a question at the end. I'll also be here for the rest of the day, so come and find me as well. Also, just a little bit of a disclaimer, despite all the fancy titles which just keep getting allocated to you with no more pay and no more time to do any of it, I am a nurse. I'm a nurse and a doctor because I have a PhD, but I am a nurse. So my paid day job is for the nursing care of people impacted by myeloma. I'm not coming at this talk from a physician medical angle, although I have spent 30 years in blood cancer and 25 just with myeloma. So we certainly do learn some things along the way, and I learn much of how to help you guys from you guys. And so hopefully I'll be able to share some experiences as well. I'm also known for talking under wet cement, and the girls at the front here will wave at me when it's nearly time and then just shove me off the podium when it's time for lunch. So we will do our best to get all through this, but please do come up and talk to me if you have particular questions. No question is too small or too silly. I will have been asked them all 50 times and sometimes 50 times a day. So please do take the opportunity to come and find me. So we're going to try and cover, we have to start at the beginning. In fact, it's quite helpful for me to know who's in the room. Who came to their diagnosis of myeloma this year? Yeah, so some newbies in the room, yeah. And who's been living with myeloma for about 5 years? Yep, mid-level. And 10 years? Lots of hands going up. So look and see where those hands are. There are more people in this room living with myeloma for more than 10 years than there are those at the beginning. But those at the beginning, there's a lot of people here with a lot of experience. Take the time to talk to those people as well. 15? Yeah, we'll just keep going. Okay, who can beat 15? Yeah, 15 beat 15. What are we going for? We're going to sell something in a minute, aren't we? Certificate. Yeah, good on you. So things are, despite when we look at the overview, 20? Good on you. That man gets a prize, a certificate, a goodie bag or something, all right? Okay. So we're going to talk a little bit about what myeloma is, how we treat it. We're going to keep very broadly to the classes of treatment. I'm going to name some of the treatments. We're going to look at what's around the corner. We will mention CAR in 1 or 2 slides because that's generating a lot of interest, and I can help describe how that fits in with myeloma. But we're also going to focus on how myeloma makes us feel, because if we can't keep people fit and well and healthy with myeloma, we can't treat them effectively. So bone disease, kidney health, general health, well-being, well-being and quality of life, managing the symptoms and side effects of treatment is a very big part of what I do, and is an important part of you guys looking after yourselves so that you can benefit from the 15 and the 20 years, because you need to be able to be fit and strong enough to tolerate the treatment that we throw your way. So particularly for the newbies then, myeloma is a cancer of the bone marrow plasma cells. We all have plasma cells. They are about 5% of our bone marrow cells, and they produce antibodies that are helpful for us fighting infection. The hallmark of cancer is we produce too many of a certain type of cell or tissue, and it's not functioning normally. So in myeloma, we have far too many plasma cells in our bone marrow, overcrowding the bone marrow and the job that it normally does, and we're producing non-functioning immunoglobulins. So our immune system is compromised, our bone marrow is compromised, and the hallmark of this disease also then is bone disease by association of where these cells are, kidney impairment, potentially because the abnormal myeloma paraprotein or these antibodies can clog up the kidney, and a very much compromised immune system, which is the hallmark of a lot of blood cancers. So those are the kind of areas that we're thinking about when we're paying attention to looking after you. So these healthy bone marrow, I do have a pointer thing here, but I probably have to point here. So we all have plasma cells in our bone marrow, and they produce antibodies, everybody in this room. But those with myeloma have far too many abnormal plasma cells, and we might call those myeloma cells, producing far too much antibody. And in health and medicine and science, we like to confuse you and call everything has about 3 or 4 different terms. So we'll call plasma cells myeloma cells. These antibodies are called immunoglobulins normally, but in the myeloma context, we tend to call it your myeloma protein, your paraprotein or your M protein. So that's what we're talking about. How much of this do you have, and how much of this do you have, and the goal being to get rid of it. The average age of somebody diagnosed with myeloma is 70. That's the average. So 50% of people are older than that. 50% of people are younger. I do have people in their 20s and 30s with myeloma that I care for, but it's rare. Most people would be 60s and 70s with this disease. Slightly more men than women, and that's the same all over the world. In Australia, we have more people, so we have just over 2,500 a year newly diagnosed, and in New Zealand, you have about 400. That's comparative for our populations. We have one of the highest incidence of myeloma in the world. We're not quite sure why we do, but it's a little bit higher than in Europe and North America, apart from Black North American men, which has the highest incidence in the world. So you probably heard, those particularly who've been at this for 10 and 15 and 20 years, that the doctor sometimes talks about the clinical features of myeloma. What are we looking for to know how myeloma has impacted you? And there's a lovely acronym called CRAB, which refers to some of those key things we're monitoring for. The C talks about calcium level, C for calcium, which is raised if your kidneys are not working well or your bones have been eaten away a bit by the myeloma cells. R is for renal, kidney, which can be impacted to a degree with all of you, but for some can have significant kidney issues. A is for anemia. If your bone marrow is packed full of myeloma cells, you're not making red cells, white cells, platelets, all the other components of blood. So just by that overcrowding, you can be anemic, and that can cause tiredness, fatigue, etc. And B is for bone disease, the hallmark. One of the commonest ways to come to a diagnosis of myeloma is somebody presenting with back pain, commonly lower back pain. And if you think of the average person who's in their late 60s or 70s presenting to their GP with back pain, it's so common. A symptom in the community, yet myeloma is quite rare. So bone disease is the hallmark. It often brings you to a diagnosis. Also explains why we like to do images and scans and things like that. There is a spectrum of myeloma. Some of you may have had a pre-myeloma stage, and that's when you have a little bit of extra protein, a little bit of extra plasma cells beginning to grow in the marrow, but you don't have any of these features. So your bones are fine and healthy, or your immune system and your blood counts are fine. There's a bit of a mid-zone that we call smoldering myeloma or asymptomatic myeloma. you're progressing towards having myeloma that needs treating, but at this stage, we don't need to jump in with treatment. There are some studies in portions of the world where they're looking at people that have a maybe high risk smoldering myeloma. Do we jump in early to treat? It's not standard in our region of the world, and even when we did have a study at my institution, nobody signed up for it because they were like, look, if you don't think you know whether you're going to help me live longer with this, I just don't start the treatment. I really don't think that's a good idea. So it's not standard in most regions of the world. And people can stay in these states for many, many years. Most of you probably came to a diagnosis of myeloma when it was causing problems and your doctor recommended treating instantly, and that's where most people come, active myeloma stage. There is also a staging system, not so much to say that you've got a little bit of myeloma or a lot of myeloma, but do you have features that may tell us your myeloma may be more aggressive? So there's sort of indolent myelomas. There's going to be people in the room that had some treatment for their myeloma maybe 10 years ago and have been very stable since that. They clearly have quite a slow-growing indolent myeloma. There's going to be people in the room that have had one line of treatment after another. And some of these features of the staging system, which are particular blood values and markers, and particularly the cytogenetic or genetic errors that occur within your plasma cell at the time of it becoming a myeloma cell, those genetic errors can prognosticate for people having an aggressive disease or not. And that can help your treating team decide whether they need to throw the kitchen sink at you or whether you can have a little bit of something and your disease might stay quite low. Because I think one of the challenges with all this new treatment is to know who needs to have everything and who can have a little bit of something and will do just as well. I do think we're probably under-treating some people, and I think we're definitely over-treating others, and we need to learn more about that. So these tests may be done on your bone marrow samples at diagnosis. They're looking for genetic errors that occur at the time of the disease. These are not errors that you pass on through to your children, okay? They're not inherited things that you had at birth. They are the hallmark of a cancer beginning. So some of the common tests of investigations are related to the blood, of course. You have a blood disorder. We do blood tests all the time. Our sisters in the hematology department are called the blood sisters, and they love to be called the blood sisters. They're constantly grabbing your blood. And that's because that's going to tell us a lot about how well you are generally, your kidneys, your bones, the calcium, things like that, your liver, etc. But importantly, that's where the marker of your myeloma sits. So in most of you, you have a clear blood protein marker called your myeloma protein, and I'm sure most of you know and might say that I'm having myeloma bloods done. What are my myeloma bloods? How are they going? Those are specific tests that are measuring for that. In some people that have non-secretory myeloma, they don't produce this abnormal antibody. They've just got the myeloma cells growing. It can be a bit trickier. And the myeloma cells generally just sit in the bone marrow. They don't float around in the peripheral blood. So every now and again, particularly at the beginning, we actually need to do a bone marrow test. Favorite test of all my patients? Not at all. We do sedate, and I would sedate. I'd put my hand up for general anesthetic if it was given to me. It's not an option. We do it at diagnosis. It's critically important because we can see these abnormal cells. We can see what they look like, and we can see what some of the features are and how many are in the bone marrow. It's very important information. But going ahead regularly, we tend to be able to see what's going on just in the blood tests. You might have another bone marrow test after significant portions of treatment or as and when things change and we think myeloma's on the move again. So we don't do them unnecessarily, but occasionally we do need to do them. The myeloma protein, the abnormal protein, which is sitting there as a Y-shaped molecule, we have a whole family of these normally. We have IgG, A, M, D, and E. Proteins like this, that when they're not behaving, coming from abnormal plasma cells, we all have them. And they're made up of heavy chains and light chains. So we also talk about kappa and lambda light chain. We're talking about sub-pieces of your myeloma protein. And that information helps type you to have, because you generally have one type of abnormal immunoglobulin being made. So you might have IgG kappa light chain myeloma, and it's really describing the abnormal protein. Some people only produce light chains in excess, and they may have light chain myeloma. And understanding the nature of that helps to measure and test for it more effectively over time. Some people produce a lot of light chains that go into the urine, and so has anybody had to do that wonderful 24-hour urine collection? It's odd, isn't it? Yeah, bizarre. Why on earth do you want to do that? It's so that we can look for this abnormal protein in the urine in a timed way. Okay, I did have a patient who left hers on the counter at the local shop, and she'd put her name and address and everything on it. And next time she went in, the gentleman said, "I think you left something there, madam." And it was she just sort of took it away, and no more was ever said about it. We don't do that often. And if you've never done one, it's probably because your myeloma is not presenting in that way. So it's not mandatory. We also do a range of scans. Scans are helpful to look at the health of your bones. So CT scans, and we do that at diagnosis and periodically, particularly if you describe a new pain or ache or problem, we want to go and have a look. Sometimes things can change in the bones before they change in the blood. You might not know that, notice an increase in your paraprotein in the blood, but you may notice an ache and a pain in the bone. So we do those regularly. There are some types of scans also that will help look at myeloma that might sit outside of bone. So has anybody had a PET scan? Positron emission tomography scan, yeah. And that you'd have an injection of a dye that hones in on where the active cells are, and that can show up myeloma that's not traditionally sitting in the bones. And we do that sometimes. It's not fully funded in our country, in Australia, but it is very useful in some people, particularly when the picture is not clear. The bloods are good, but you've got other features. We want to look a bit more at that. So there's a range of different types of scans. One thing to say about scans, if you are having a CT scan, sometimes for normal CT scans, they like to put a dye in, a contrast dye. It shows up tissues and parts of the body more effectively. We don't always do it. If you are worried about your kidney function, or you haven't had a recent blood test to check your kidney function is okay, you should just decline the contrast dye until the scanning people have checked with your doctor, because contrast dye can harm kidney. Okay, so it's a bit of a check, and there's sometimes a checklist. When did you have a blood test? How is your kidney function, before they give you the contrast dye. So we use these tests to help measure how much myeloma is around and how well you are responding to treatment. And there's a particular scale that is used and grouped into different categories for that. But we also look at your general health with the bone scans and PET scans for any extramedullary disease or some of the other values in your blood. You'll have these. If I'm scooting over quickly, I'm aware of the time pressure we're in. But you can go back and look at these. I think they'll be available quite quickly, won't they, on Zoom? And when we put this together, this is a patient of mine who's been living with myeloma since 2011, showing her paraprotein as it goes through periods of being quite high, having a change in treatment, and that paraprotein coming back down, and her responding to treatment. There were periods where that paraprotein disappeared, but they do draw a line between the dots of one value to another, and sometimes it looks like it's still there. And this demonstrates that myeloma follows a general path of being active, needing treatment, being not active and in remission or good response for a period of time, and then needing treatment again. And that's the course of of myeloma over time. The goals of treatment are to control the underlying disease. At this time, we don't have a cure for myeloma, but we have an increasing range of treatment. The treatment approach tends to utilize a combination of a corticosteroid, a traditional chemo drug, and a newer target. Well, not so new these days, a novel target. And in combination, those treatments tend to work better than a single drug on its own. We definitely treat people in different ways. So my 20 to 30-year-old that was diagnosed is treated far more aggressively than somebody that comes to us that might be 85, and that's somewhat commonsensical. The depth of the response is important and tends to translate into the disease staying away longer. So we do tend to push on with consolidation and maintenance to keep the myeloma proteins down. And then I've mentioned before the importance of looking after bones, kidney, immune system, and any side effects, because if we can't do that, we can't treat you effectively. We know for some certainty globally around the world that these are what we call survival curves, with an uptrend being where we want to be, that people are definitely living a lot longer with myeloma. I've been at this for 30 years, and we've probably nearly doubled the survival in 30 years, and that's quite a pace of change. We clearly want that to get improved, and there is no sign that that survival curve is plateauing out. Things will continue to improve, and that's because we have different drugs and different approaches and targets to treat myeloma. The range of drugs that we have are listed here. I'm not going to go through each one because I'm going to go through each of the ones that we commonly use. But as I said, the classes of drugs are batched on the slide. We tend to take one from chemotherapy, a steroid, and then one from the other classes to put them together. For example, RVD or CVD, and these acronyms are the names of the drugs. And we know that that approach tends to be more effective. For those that want to delve a little deeper, the Myeloma Scientific Advisory Group in Australia, that's made up of New Zealand clinicians as well, is the group of scientists and doctors who are leading the way to set standards for how to best treat this disease. And you can access those clinical management guidelines, and there's a whole range of them, some looking at bone health, imaging, how to treat people with amyloid, myeloma up front when it comes back, etc., from myeloma.org.au, and you can readily get those as a consumer as well. So as a taste of what's coming, and we'll come back to some of these drugs, there's a whole range of new treatments coming. Some are new treatments in the same class. So we started with thalidomide, we then went to lenalidomide, we've got pomalidomide, and now there's this class that are cousins of those called CELMoDs, which are getting more potent and more targeted, and hopefully with less side effects. So they're a similar class. We have monoclonal antibodies. You guys would have heard of daratumumab, because I know we're working very hard to get more access to that in New Zealand, but there's a whole range of other drugs coming through in that class. Probably some of the most exciting new treatments are in the categories of CAR-T, you may well have listened to the session before, or bispecific antibodies. Both of these treatment approaches are looking to harness your own immune system to recognize and kill your own myeloma. And those are likely going to be game changers in this place. We just need to navigate our way through, get better access, study, and look at what the sting in the tail may be with some of these treatment approaches, and how we can embed them in time into routine practice in our regions as well. I'll come back to a couple of those. I'm getting anxious with the time. I'm going to go through reasonably quickly some of the common drugs, and I'm sure many of you in the room have had these. Bortezomib is very well established as an effective drug in myeloma, also known as Velcade, and there are generics available as well. It's a proteasome inhibitor and inhibits something within the cell that causes the cell to die. It's given these days as a subcutaneous injection under the tummy in combination with dexamethasone for sure, and commonly in combination with something else. I think cyclophosphamide, bortezomib, and dexa is a very well used standard here. We use it also in Australia. It can be combined with the immunomodulatory drugs, and another partner that's quite common is the lenalidomide or Revlimid, and that's a common combination that we use in Australia up front. But pretty much studies are exploring partnering these drugs with each other. Generally what we don't do is put two in the same class together. Kind of makes no sense. So you wouldn't use thalidomide and Revlimid together. They're in the same kind of class, but you do mix the classes up. The most important symptom and side effect of this drug, which is very important to recognize and manage, is peripheral neuropathy. It can cause damage to the nerves, and that damage can limit our capacity to give you more of this drug ahead. So it's important to manage for that, and we'll have a couple of slides on that. There's collateral damage as we start to treat the myeloma and kill off these bad cells in your bone marrow, is that healthy cells get damaged as well. So lowered blood counts and lowered immunity are the hallmark of all treatment for myeloma. There's also an increased risk of reactivation of shingles with this class of drug. It's very common and important that you take the antiviral medication when you're on this drug or any drug in this class to prevent that. All medications can cause an upset to the gut. It can cause diarrhea or constipation, very helpful which one, but it can cause both. In my experience, it tends to cause a little bit more loose stool around the time of the drug than it does generally either of those issues. Neuropathy is known to all of you in this room, I'm sure, but it's really probably the most important side effect we need to manage in myeloma, because as these drugs can damage nerves, can cause symptoms that changes in the way we feel, move, or function. So whilst we talk about sensory neuropathy and tingling in the fingers and toes, and it can be cramping and shooting pains as well, can also impact blood pressure and gut and all functioning in the body. So people can get a bit wobbly, and if you stand up too quickly, you can feel quite dizzy. That can be a type of neuropathy, okay? So all these symptoms and concerns, you do need to make sure you report to the nurse giving you these drugs or your doctor. Some of the common symptoms are there. I remember talking to a guy and saying, do you have tingling in your fingers and toes? And he said no, and then he told me a story about walking on cauliflowers. And that was just his way, and he hadn't put two and two together, but he really did find it difficult to walk because of that. These are all neuropathy type symptoms, including the dizziness that I mentioned, because it can impact blood pressure, particularly as you move between lying, sitting, standing. We just need to slow down and do that a bit slower. There is no drug or intervention that we know that will directly treat neuropathy. So it's about preventing it and allowing the symptom to decline and improve over time. Unfortunately, that means having to reduce the dose of these drugs or sometimes the frequency in which we give them. That's good if your myeloma is under control. It can be a little trickier if your myeloma is raging a little bit. Sometimes we might swap out one drug for one that is not neurotoxic. There's particular painkillers that we use that target nerve-like pain more effectively, and they're listed there for you. Duloxetine is particularly useful, and Lyrica is very commonly used as well. Myeloma.org.au has a really useful patient guide on neuropathy, so if it's a problem for you, do download that. Some other commonsensical things you can do. There is a role for acupuncture in reducing the symptoms of neuropathy. Time is the best healer for neuropathy and not having the drug that causes it. And there's an increasing body of evidence that suggests that physical activity and exercise is important for so many areas of health, but it can also reduce the symptoms of neuropathy as well. A lot of my patients have massage or use circulation boosters or supplements such as magnesium can reduce cramps. Tonic water can, plus and minus gin. And there are some supplements that some people swear by, but there's very little science evidence. Vitamin B, alpha-lipoic acid, things like that. I do caution if you are taking any supplements, though, to just check there isn't a direct interaction with the medication you're on. And some supplements, particularly if you don't know where the source of that supplement is, can cause kidney and liver toxicity. So be very cautious. Talk to your community pharmacist if you're unsure whether you can take it. Generally, alpha-lipoic acid and vitamin B complex is very safe, though. I've not known an interaction there. Let's move quickly through some of the other drugs. Lenalidomide would be familiar to many of you, also known as Revlimid, and there are generics on the market now increasingly. Australia has switched to generics recently, making these drugs more affordable for those that do supplement and self-pay to add to a regimen they may be on. Not saying that that's what we should be doing, but it is a game changer in the last 12 months or so. Taken as tablet, ideally away from food. You shouldn't have this one with a food, and I often tell my patients to take it at bedtime because you don't generally eat and go straight to bed. Given in combination with dexamethasone, and this drug and this class of drug can increase the risk of blood clots. So it's very important to take a blood thinner. That may be an aspirin, or if you're on a blood thinner for other cardiac reasons, then that will be fine as well. partnered commonly with the proteasome inhibitors, so bortezomib is a common partner, but some of the other classes are utilized outside of our region, but in other regions of the world and in clinical science. Some of the common side effects, I always say to patients, it can cause a rash. If it is going to cause a rash, it's going to do it very quickly. It is something you need to tell your doctor or nurse about because it can be a sign of a hypersensitivity. It can be quite dangerous. It can cause lower blood counts, particularly the white cells, and make you a little bit more susceptible to infection. The bread and butter for myeloma is minimizing the risk of infection. If you do have an infection, get onto it quickly. Very, very, very important message. It rarely causes peripheral neuropathy if you don't have it already, but I do have a few patients who would swear that it has made their neuropathy a little bit worse. And in the long term, if you're on this drug for more than a year or two, and I have patients who've been on this drug in the maintenance setting for 5 or 6 years, it can cause some chronic diarrhea, which we think may be driven by bile malabsorption syndrome. So reducing the amount of fat in your diet or potentially taking something like Questrin can help. So if that's an issue for you, talk to your doctor about using some strategies for that. We do still use thalidomide. It's a very useful drug in the same class as lenalidomide, but it causes a lot of peripheral neuropathy, and we have to be very careful with that. It also was developed as a sedative, so it'll make you sleepy. You must take it at bedtime, and can cause constipation. Doses vary. I can think of 2 or 3 patients who remain on thalidomide 50 milligrams once a day with a sniff of DEXA for years, and it's keeping their myeloma at bay. Would their myeloma be at bay if we just stopped it? Maybe it would, I'm not sure, but they're a bit nervous about that. So we do still use this in our clinical practice as well. When we put this pathway together, we come up with a picture of treating myeloma that includes, particularly at the beginning, having some induction to get a response, consolidating that response with a stem cell transplant or further induction therapy, and then maintaining that response. And that's a typical pathway. It used to be that we had lots of periods off drug, but commonly now you may remain on a little bit of something just to keep the myeloma markers down. And we do that commonly with either Cybord-E or RVD, plus or minus a transplant, and some maintenance lenalidomide going forward, or thalidomide we used to use in that setting as well, which can work. In the essence of time, I might not talk about transplant, how we're doing 8 minutes to D-Day, because I want to get to some of the newer stuff. But transplant is about giving a high dose of melphalan to further cause response in the myeloma, and then rescuing you with some of those lovely stem cells to make sure your marrow regenerates after that. It's a very effective regimen, and we still use it, and it's not going anywhere anytime soon. Corticosteroids are a very important drug in the treatment of myeloma. They kill myeloma cells on their own. So high-dose dexamethasone on its own is a treatment for myeloma. But together with the other drugs, there's some synergy, and it makes the other regimens work better. But there is a bit of a sting in the tail in that steroids can have quite unpleasant side effects, and as many of my older patients with rheumatoid arthritis say, they can have some pleasant effects as well, because my sore knee and my sore hip is a lot better on my Dexa day because they're very powerful anti-inflammatories. But they are important in the treatment of myeloma, and they can cause effects that are not just physical, but they can cause, there's some patting between husbands and wives going on now. Yes, they can cause some irritability and some emotional, I don't know which one has myeloma, but yeah, you're not laughing. No. They can cause some angry men and some, in my experience, very efficient women behavior, very efficient, get up to a lot of proactive stuff when we're on steroids, but the men get angry and walk around the field generally. That's a terrible generalization. In red is the quote of my patient just a couple of weeks ago, and he came in, and he's a younger guy, he's my age, 50, and he came in, and he was probably like you, he was a bit sort of like this, and the doctor said to him, have you taken Dexa today? You're a bit angry. And he said, I'm not angry, I'm just bold and courageous. And he was out to just sort anything. It can make you feel like this, and we're laughing about it, but it can be pretty hard to figure that out. It tends to be predictable. So I think you would know when your husband's on Dexa and what he's taken, you flush anyway. And it's learning that pattern that can help you cope and manage. These predictable patterns of not sleeping, poor energy, feeling bold and courageous or an angry man do tend to be quite predictable. And sort of learning that pattern and finding ways around it is key to managing with it. Some other key side effects, though, if you have unstable blood sugars, it can upset those. Pay attention to your blood sugars. We do see an increase in cataracts. That's the 10-minute wave, is it? That's not because I have cataract. And so we do have to pay attention to visual issues. It can really make your ankles swell up, ladies particularly. You get puffy ankles, and we might need to reduce the dose for that. Again, walking, mobility, massage, one of the best ways to help with that. So there's a whole gamut of issues related to that drug. The key to managing that is getting used to it, but is dose reducing. And particularly when your myeloma gets under control, we like to start with reasonable doses. We will bring those doses down quite effectively. So when you're going to your visits, and the truth tellers, I call them, the wives of angry men that go to their visits, if you're having a problem or you think he's having a problem, you make sure you're talking to the hematologist, because there can be dose reductions that are very easily made that can have significant impact in reducing some of those symptoms as well. I mentioned bone disease, very important part of myeloma. We have cells that make bone and eat bone, and this is happening in a state all the time. I think we have a new skeleton about every 7 years, apparently. What happens with myeloma is our bone is eaten away faster than it is built up. So treating the myeloma is management of that, but then having bone strengthening drugs is an important part of treating myeloma. Scans and tests to keep an eye on how the bones are and how healthy they are. Maybe even some orthopedic intervention if you need a bone fixing or a plate or things like that are pretty standard. So important to focus on that. Some of the different things we use, we would recommend calcium and vitamin supplementation as long as your calcium level is normal. Regular bisphosphonates for a period of time, breaks in that. Radiotherapy can be very effective if there's a painful area in bone, in looking after myeloma bone disease as well. The kidney is a target organ as well, because this abnormal protein, if it's in high levels, can clog up the kidney. And the best thing we need to do is monitor kidney function and pay attention to kidney health. A lot of other things that you may take over the counter or medication can cause harm to the kidney, and the best thing for kidney health is keeping well hydrated. Pay attention to that. It's the best thing you can do, okay? As well as us treating your disease very effectively. I want to spend the last few minutes talking about some of the newer drugs. Pomalidomide, not so new, but we use it in the relapse setting. It's in the same class as the immune modulators of Revlimid. It's a very effective drug partnered with dexamethasone, plus and minus cyclophosphamide, or other drugs that if we have access to them. I've got a lot of patients on POM Velcade Dex or POM Cyclodex, and the common toxicities are similar to Revlimid: rash, lower blood counts, fatigue, etc. But if it is an oral regimen, it can be very effective and very convenient for people, particularly if you don't live near a treating center. Daratumumab is a monoclonal antibody. And what is that? Well, there are antibodies on the surface of myeloma cells that say, hey, I'm a myeloma cell. If you can manufacture an antibody that is given, that targets that flag on the myeloma cell, it can work away to cause myeloma cell death. And that's principally what monoclonal antibodies do. This drug is given these days subcutaneously as an injection over a few minutes into the tummy. We used to have to give it IV over 7 hours. We now give it in 5 minutes in the tummy. It's given reasonably frequently to start with, then less frequently than once a month. Commonly with the other drugs, dexamethasone for sure, and partnered with some of the other anti-myeloma drugs as well, such as bortezomib or lenalidomide. Its side effect profile is very good in that there aren't many side effects that I tend to have to talk to patients about, but I do need to talk to them about the side effects of the other drugs they might be having with it. Principally, the thing for us delivering this drug safely is you can have a local sort of hypersensitivity reaction the first 1 or 2 times you have it. low level risk of that, sort of 10%, but we do give you some pre-medication to calm down the body. So when it gets the drug, it doesn't sort of get all coughy and sniffly and tickly in the throat or the chest, etc. So some paracetamol and dexamethasone and an antihistamine is pretty standard to have about an hour before this drug is given. The other thing we're doing is monitoring the blood counts and generally increased risk of infection when you are on any treatment for myeloma. We hope that this is going to come a little bit more easy for New Zealanders. We've had it maybe for a couple of years in Australia and use it very effectively, particularly now it's subcutaneous. I want to mention three more things before we have some time for questions. Selinexor is a different class of drug. It's a tablet, belongs to a unique target called selective inhibitor of nuclear export. Basically, by inhibiting a process in the cell, it causes that myeloma cell death. This drug is a tablet. It is given in combination with other common Velcade, Revlimid, etc., DEXA drugs. Once a week when it's packaged with other things, or twice a week when it's on its own. The main side effect, and this is available on compassionate access in New Zealand. I checked before I came over. We have patients, in fact, the lady I showed you with the up and down protein, she's just started this combination and her proteins come back down again. The main toxicity of this drug, though, is it does cause some nausea and GI upset. So it's very important that we manage prophylactically with anti-nausea medication, a bit like the traditional chemotherapies we used to give. We had to give very standard anti-nausea medications, and we have to pay attention to make sure you're eating and drinking and you're staying well hydrated, etc., for patients that are on this drug. So that's another class. Carfilzomib is in the same class as bortezomib or Velcade. It's a proteasome inhibitor. It's given intravenously, packaged with dexamethasone plus and minus some of those other drugs, cyclophosphamide or one of the imids. It's about a 30-minute intravenous infusion. Unfortunately, we're not able to give it subcutaneously. And its main, you have to have anti-shingle drugs. Main issues are increase in blood pressure and some cardiotoxicity. So we have to be very cautious if we're giving this drug in people that have a pre-existing heart condition. I have a lot of patients on this. You do need to attend either once or twice a week in terms of the schedule to have this. But the toxicity outside of keeping an eye on the blood pressure is very manageable, I find. So what's coming, and I think we all know that CAR-T is certainly just around the corner, but if we look at this cell, just shows us that the new approaches in myeloma are about harnessing your own T cells, okay? And we have two ways of doing that in myeloma. One is through CAR-T approaches, where we take your T cell, we genetically engineer it to target your myeloma and infuse it back in. The other is bispecific antibodies, which are quite similar, but we give the antibody to you that grabs the T cell, grabs the myeloma cell, and causes myeloma cell death. There's a few different classes of bispecifics. We're seeing very good early high response rates and durable responses. So whilst these are not treatments that are coming in and curing myeloma, they are treating people who have run through the gamut of other treatments very effectively and seem to be keeping myeloma at bay a little bit longer than some of the other strategies. I won't labor the point around CAR-T, but this is a cartoon that tells you the process of how we do that, and you can look at that afterwards on the recording. We do have some studies in Australia. It's not standard practice. We can't access CAR-T in Australia, but I work at a center that does have some CAR-T studies, and we have sort of small numbers of people even upfront having CAR-T and predominantly at relapse, and we're having some good responses with that. And we're working with our government to try and get CAR-T on being reimbursed. We're probably a few years away from that yet. And when we do, it's going to come in the heavily treated. It's not going to come in right up front. It's going to be for people that have gone through a number of years of standard approaches. That's where CAR-T is likely going to fit. And we're going to learn and continue to learn from our colleagues in the US who have greater access. They have greater access because they have a heavily insured population. Large portion of America is not receiving any treatment if they're not insured. So keep that in mind. We have a good health system here. There is a sting in the tail for these T-cell therapies, not least immunological. You can get some if you start fiddling around with your immune system and T cells, that's going to fight back a little bit. And you can get these cytokine release syndromes. People can get very sick, very immunocompromised, and we're learning our way of how to manage that in people and delivering these drugs safely, monitoring for them very closely in the first month or so, and then having an approach to keeping their immune system strong in the period of recovery. And some of these toxicities are listed here. I've also listed for your review, but I do want to stop and take some questions, the importance about immune compromise and protecting your immune system. The world has been through a pandemic. We've all caught up with knowing that masks and alcohol wipes are a good thing, keeping a bit of distance, and that's kind of myeloma 101 for you, and it has been throughout. Keeping a healthy immune system is critical to staying well with myeloma and tolerating the treatment. So please, please, please do take your prophylactic antimicrobials. Do know the times you're at risk. Wear masks if it's a risky time, and stay away from people that have infections, and vaccinate, vaccinate, vaccinate. It's the best science we have to help protect. And there are improvements in vaccinations for all sorts of flu-like syndromes, COVID, Shingrix, all those kind of things. Please be very cautious and careful. There is a guideline for your reading pleasure on the Myeloma Australia website that's written by the doctors that puts this out quite clearly for you as well. You can take that guideline to your GP or your practice as well. So in summary, myeloma is a cancer of the bone marrow plasma cells, principally affecting your immune system, bones and kidneys. Not yet curable, but increasingly treatable. And we have people in this room who have been living with myeloma 10 or nearly 20 years. I have a lot of patients who are definitely 10 and 20 years. I think I've got a guy who's 28 years. So he gets the certificate, actually. Oh, he's not here. He doesn't get the certificate. He's not here. Treatment includes a combination of different drugs. Just because a drug is new, it doesn't mean it's going to be better for you, okay? And I do think we probably are over-treating a portion of people. It's about getting response and staying well and keeping that marker down. T-cell therapies are going to be a game changer for sure. And when we come back together, I'm sure even next year or the year after, we're going to be talking a lot more about that. And I'll leave you with some references there to global myeloma patient groups. And I have a whole host. Most of the doctors and researchers that work in myeloma in this space are attached to one of these charities. So in Australia, we are here, you work with your medical colleagues, etc. So they're good places to go to get really good, credible information. I'm really happy to take some questions because I know I've been very brief in certain areas.
No, that's brilliant.
Yeah.
I'm sure, like me, you all found that really informative and very enjoyable as well. I mean, a whistle-stop tour. We do have a short time for questions, but as Tracy says, she will be hanging around for a bit of lunch until her flight goes later. So she will be around if you want to just have a chat later.
Yeah.
So does anybody have any questions?
Please, there must be.
Natasha will come with the microphone.
Or even comments. I mean, for those in the room, there's 3 or 4 people in this room that are starting this journey this year. Okay, and there's some of you in this room that are 20 years ahead of it. I mean, do maybe start with one of those? Do we have some words of wisdom, or for those starting, or things that you wish you knew at the beginning, maybe? Gentleman at the back, yeah, and then this lady maybe here.
Really promote or you talked a little bit about trials.
Yes.
You just mentioned it. I'm on a trial.
Yep, good on you.
And a trial for many that I come across, if you get that pun. But a pain in the neck. It's been very successful for smouldering myeloma.
Yeah. So you're on the smouldering myeloma trial using what?
Using isatuximab, lenalidomide and dex.
Yeah.
And I've just finished lenalidomide and dex, so I'm hoping for some more energy.
Yeah, yeah. So you make a good point. Yes, there certainly is some work going ahead as to whether we can keep smouldering myeloma smouldering for sure. And I think because we have smaller numbers of people, we find it harder to get people on that study. So great for contributing. I had some slides on clinical studies and I took them out because I didn't have enough time. But clinical trials are critically important because they inform how we then understand to use these drugs more effectively in which people. It also, in our region, is one of the best ways to get access to better treatment, or potentially better treatment, because you can get standard approach plus something, or you can get a combination that is not available in your country, reimbursed on whatever health system you have. So we have a big trial center. We have about 15 myeloma studies running at any one time at our center. And every time we have a new diagnosis or a new progression, the first question we ask and we consider, do we have a study for that? And if we don't have a study for that that's offering us something better, do our colleagues down the road or does anywhere? And we pitch that as an option to patients. And I would, if you're not offered that, then that should be a standard question on your agenda when you have a consult. Is there a clinical trial that I could participate in? People do better on clinical trials because there's a little bit more they're treated with potentially better treatments, but a little bit more tests and investigation and attention is paid. You have trial staff and dedicated staff. So generally people worry about being a guinea pig or something, but we know universally, whatever the study is, people do better on a study. So thanks for flying the flag. The challenge can be where that study is accessible. You might have to travel. And also there tends to be a little bit more tests, those bone marrow tests that you don't like. There's more of them on studies generally, because studies are about gathering as much information as we can to ask a very specific question and answer that very specific question. So good on you. And enjoy the energy when you get off drug. Yeah. The lady here had a question or a comment. Yeah.
From my point of view as being the carer, I found that it was a pretty big subject to get my head around, and I got a little bit sidetracked listening to this one and that one and the rest of it, but just decided in the end to listen to the experts and just absolutely trust in what they were telling telling us as a couple, and just going and trying to find the calm spots in amongst all the upheaval of the initial diagnosis.
Yeah. Great comments and great advice for those starting off. Hopefully the team, and I think there's been positive things said about the health teams, are going to know, modern healthcare requires us to inform you about everything, every symptom, every side effect, everything that's going on. And it, to a degree, you need to be active participants and not just accept what we say, but you can also just devolve that responsibility back to us and say, look, let us tell you about everything. And then your questions, maybe I need to understand this, I need to understand that, but what do you think? What is the standard approach? What do we know that people do better with? So if you take that burden on having to understand it all and make those decisions, it's quite overwhelming, isn't it? And stick to the sources of information and know where to get support as well when you have those additional questions. We'll talk a little bit later in the closing talk about the importance of self-care and and carers and information gathering, but it really is critical. So having learned that, to sort of say, I can't take all of this on, I'm going to go along, I'm going to be present, I'm going to listen, but I'm going to trust the team that look after me. That's an important lesson to learn, and not everybody gets there. But do trust your team.
Got one last question at the front here.
Yep.
Yeah, but I'm sorry, it's more a question for the ones that have experienced myeloma for a long time.
Yeah, great.
My wife is, she's young, and I think myeloma being a very slow death sentence, if I can say that. The most important thing is asking you guys is, over your experience, the mind, keeping you positive, and because everything else follows the mind, keeping up the positivity, keep pushing, day by day. I just wanted to know what's a couple of things that has really worked for those that have battling with this for a while.
Angry man there, he's going to tell you exactly. No, really good point and very common.
So more question, when were you diagnosed? Okay, so that's not too bad. I know when I was diagnosed, we called it the oh shit moment, which is a 3 to 4 months where you cry and all that sort of bullshit as well. Not bullshit, but it's real stuff. And it's probably just get on with life and try not to think about it. So I do the research, that's me, but I also try and get on with life. So yep, there's some days where accounts go wrong, or when I get annoyed with some things that I just think, bang, this is a heavy. But the rest of it, just get on with life and try not to think about myeloma, because there's so many other things that we've got to deal with, and that's the way I deal with it, and try not to annoy my wife and kids. But that's probably the simplest thing, trying not to think about it a lot, and just because there's so many things we deal with, and that's just my advice. So, might sound stupid, but that's my way of trying to deal with it. Others might have another way.
Yeah, thank you. And I think it's also not so much ignoring it and pretending it's not there, because it is a real thing, but focusing on, so when you have a bad count or you have a new treatment that's initiated, focus on that, gather the information, trust the team that's looking after you, allow that part of time to occur and be there and sit there, but then focus on some positive a bit more. So it's not about ignoring the negative, it's about being able to focus on the positive as well. One of the best things you can do is be somewhere like here, when these meetings are on and you come and you meet other people that have been living with this a long time and have great suggestions about how they manage, trusting their team and focusing on the positive, and make sure that you are scheduling non-myeloma time and non-blood time, because that's really, really important as well. It's really tough for the carers, really tough, and often, I think, not diminishing, tougher. Because you're sitting in a very uncomfortable space. I really do feel for you. And your job is there to protect your wife and your family. And you can't protect them for what they have, this significant blood disorder. But you can be there to trust your team, take the advice, apply the treatment as and when and what you want to, and schedule time that's non-myeloma and non-blood, and engage with those activities, because it is the small things, the walking the dog, the having a nice meal, the going to the movies, scheduling a holiday or something. That's what life is all about. So make sure you don't forget that. Don't ignore the myeloma, but just put it aside occasionally. Focus on something else. Wish you well. Help them to live well. Yeah.
We had the option with the injections that Stuart needed of me administering them rather than having to go to the hospital to have them administered. And
Yeah.
I'm not a nurse, I'd never injected anybody before, but I thought, well, I've got a bit of reasonably stoic and lots of areas. I thought, why can't I learn this? The training they gave me was wonderful, and it meant that we could step outside that medical bubble and not have to go and wait and take a special trip in, and we reclaimed the day, really.
Yeah,
and
well done.
I would suggest to anyone who feels they could take it on board is to go down that track, because it just freed up so much time.
Yeah, and it's not so hard, is it? You don't need to be a nurse.
And also, your partner's got to be confident that you're going to do it.
You're going to do
of
it. Yeah,
course.
you really can't do anything wrong in injecting. You can't, other than dropping it on the floor.
I had the attitude somebody was going to stick the needle in, so it might as well be somebody that I love.
And you give it a slap around the head if it wasn't done well. You can't do that to the nurse. Well done. Yeah, reclaim the day, absolutely. And such an important thing. We don't have that at my hospital because of some complexities, but increasingly they do. Be able to self-medicate even with infusional stuff, which is great. And I think that's an area that we'll see more. Community-delivered treatment, so you're not having, particularly if geographically you're away from a treating centre. The CAR T treatments in the US, they do as outpatients now, and they're pushing everything into the community. Of course, you have to have the resources to support people, and the burden often falls on the loved ones to take that responsibility. But good on you for putting and you haven't given a clip around the ear yet? No? Good on you. It's lunch.
It is. She took the words from my mouth, but again, thank you so much.
You're welcome. You're welcome. Thank you.
This is just a little
Oh,
bit.
thank you.